So while we're waiting for extra people to join us, I'll just do some quick introductions, but this will be repeated anyway during the webinar tonight. So I'd like to introduce, on behalf of the Commission, I'd like to introduce Dr. Oliver Frank, who's a specialist GP in South Australia, who will be presenting our webinar tonight. Dr. Oliver Frank was also a member of our topic working group at the Commission for the Colonoscopy Clinical Care Standard. We also have on our webinar tonight Professor Anne Duggan, who is a clinical director for the healthcare variation at the Commission. And Anne also co-chaired the topic working group for the Colonoscopy Clinical Care Standard, alongside Dr. Ian Skinner. Just some housekeeping during our webinar tonight. If people would like to ask any questions, at the bottom of your screen, there's a Q&A tab, and in there you can put some questions. Please don't use the chat. I know a lot of people are familiar with chat. It's the Q&A. Please use if you want to ask any questions. And the other thing I'll just highlight as well before we start our webinar, during the webinar tonight, we will have some polling questions, and they'll be prompted during the webinar, just if you could answer some of those polling questions. Okay, I'm going to hand over now to Dr. Oliver Frank to continue with the webinar.
Thank you, Siobhan, and good evening to everybody for joining us for this webinar in which we're going to be discussing what the colonoscopy clinical care standard means for GPs. For those who just arrived, I'm Dr. Oliver Frank. I'm a GP in the inner northeast suburbs of Adelaide, and I was a member of the working group that developed the standard. We also have with us Professor Anne Duggan, who is a gastroenterologist and is the clinical director of healthcare variation at the Australian Commission on Safety and Quality in Healthcare. In the spirit of reconciliation, the Australian Commission on Safety and Quality in Healthcare acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Now for GPs, this is probably a big question. What is this standard? What's it all about? It's a statement of the quality that is expected in every part of the process in a patient being referred for and undergoing colonoscopy. The standard is being implemented in all of the places in which colonoscopies are performed. The standard has 9 quality statements, of which the first, about assessment and referral, and the last, about reporting of the findings and the follow-up, are obviously of most interest to GPs. The first quality standard says that the referral will contain enough information and the right information for the receiving clinician to assess the appropriateness, the risk and the urgency. And using that information, the colonoscopist then can allocate an appointment that is appropriate for that patient's needs. And now we have our first polling questions. Hopefully you've all had a chance now to fill that in, and we'll
Thanks,
hear
Oliver.
what the answers are. Yep.
Thank you.
And somebody's going to tell us the answers.
So the first question, which was what template or referral form, if any, do you currently use when referring patients for consideration of colonoscopy? 7% use a referral form or template that has been supplied to their practice. 5% use one that their practice has created, and 5% don't use a template or referral form. And the next question, if you do use a template or referral form, is it on a piece of paper that you write by hand? 4% said yes, 13% said no.
All right, thank you. That's interesting to hear. Now, as part of the development of the clinical care standard, the Commission has developed a referral template to try to help GPs to provide the information that's needed. And that template has been embedded into 5 of the widely used clinical software systems in general practice. As a paper document, the template has 3 pages, and here you'll see page 1, which collects the patient's identifying details, the referrer's details, and what the patient is being referred for. Now, at the bottom of that, there's places where you can mark if the patient has signs or symptoms or positive fecal occult blood test. All of those things can be marked along with any investigations that have been done. Now, you will note there's nowhere there where a patient who is well and asymptomatic and at average risk of bowel cancer would be referred for a colonoscopy. And the reason is it is not appropriate. It's not recommended to use colonoscopy as a screening tool for people who are well and asymptomatic and at average risk. And that's one of the aims of the development of the standard. On the next page, you can mark if the patient falls into a surveillance category, that is for people who are known to be at higher than average risk or who have had previous abnormal findings. Below that, there are places where more clinical information can be provided. A lot of it you'll see in a minute brought in automatically, and some information down the bottom about the individual patient's needs for care after and during the colonoscopy. The 3rd page of the paper referral has some guidance about working out into which surveillance category the patient falls. Now, we've made some videos to show how you can use the referral template within 3 of the most common clinical software systems, and we have screen images of a couple more. And we're going to play those videos now. This is the process and best practice for using the colonoscopy referral template. Here I have a patient who's had a positive fecal occult blood test. I've explained that colonoscopy is indicated, referred her to the video. I go to the letter writer. I already have the template stored as a favorite one. I can bring in the patient's medicines, problem list, relevant investigations, and then mark the rest of this as appropriate. I have to type in the name of who the patient's going to see, and then I can work my way through this, marking very appropriate boxes, typing in the alcohol, the BMI, and the reason for referral, the positive test. If it was through the National Bowel Cancer Screening Service, I can mark that. Examination findings, the hemoglobin, I've already said, will be brought in. And that's enough for that situation. If the patient is in a high risk group under surveillance or has had previous abnormal findings, I can mark the appropriate one of those. And mark here whether the patient is independent, whether they need to stay overnight, and that generates the form, which I can then view and save and send, preferably by secure messaging. And here I can find a list of people, which should include the person I've referred to, and save it. Okay, next this is the process and best practice for using the colonoscopy referral template. Here I have a patient who's had a positive fecal occult blood test. I've explained that colonoscopy is indicated, referred her to the video. I go. That's better. This is the process for completing the colonoscopy referral template in Medical Director. I have a fictitious patient, aged 58 years, has had a positive FOBT test, and I've explained the indication for colonoscopy, and advise the patient to look at the video that's available. Now I want to write the referral. I go to the letter writer, templates. I can look in supplied templates in the referral forms, and start that off. Medical Director offers to help me with the list of people I might refer to. I can choose one of those. I can choose the medicines to bring in. And then we can see that the patient's information has come in. I can mark the patient's gender as appropriate, whether they're privately insured. These other fields, if the patient might be a smoker, how much alcohol per week, the patient's BMI. I can mark that this is because of positive fecal occult blood test. If it had been through the National Bowel Cancer Screening Service, I can mark that. And mark any of these other things that matter. There's some prompts to bring in relevant investigations if there were any of those done. And then I can write some notes. There's not much to say in this case because it's fairly self-explanatory. There's a section here for people who are under surveillance because of high risk or previous findings, and there's guidance at the end on which of these categories the patient might fall into. So by reading that, I can come back here and mark up whether the patient does fall into one of these categories or another. The patient's current medicines have been brought in, and these are all very relevant, of course, for colonoscopy, as is the possible problem with propofol. We can mark whether the patient is independent, whether they need to stay, and the patient's past medical history has been brought in. That's it, and I can then save that and either send it by secure messaging such as HealthLink or Argus or ReferralNet or Medical Objects, or I could print it on paper or use other ways to get it to the colonoscopist. Okay, and finally in ZMed, the colonoscopy referral template is not supplied with ZMed. To get it, you have to go to the ZMed website and go to its library of clinical templates. It's in miscellaneous under C for colonoscopy, and this is a standard process in ZMed. You download it and then have to import it into your ZMed system. This is often a job for the practice manager. Once you've got it in the system, this is how to use it. Here we have a fictitious patient who's got a positive fecal occult blood test, and I've explained here to the patient that colonoscopy is indicated and referred her to the video on the Commission website. To write the referral, I use the standard process. I choose whoever I'm going to refer the patient to, as usual. Dr. Sam Costello, one of our colleagues, and then choose the template, which in our system has been filed here under the possible referral templates, and then start writing that referral. ZMed offers to include any progress notes that I might want. I could choose the one I've just made. And here we have the template ready for me to write some more details. Now it's brought in some of my details and the patient's information, and I need to mark the patient's gender, which has to be done in this way in ZMed. If the patient was privately insured, I could mark that, and if we have a record of their Aboriginality, then we can put that in and mark up these other choices and what we're referring the patient for. Now there is a record in ZMed of smoking and drinking, but it's not brought in automatically. So ditto for this. So we don't have a provisional diagnosis. We do have a positive FOBT. It was one that I requested, didn't come through the National Bowel Cancer Screening Service. If it did, I could mark it. And if any of these others applied, I could mark them. And you'll see there's a range of pathology investigations that would be useful if they were there, but the patient hasn't had any of these. Further down, I can make a note. Now there is a past history section, and in this case the patient is not. Now this is for symptomatic people or people with abnormal signs, like a positive fecal occult blood test. This is for people who are under surveillance because they're at high risk or previous findings. Further down you'll see that my progress note has been brought in. The patient's list of current medicines has been brought in, and these are a bit significant for colonoscopy. It's probably better if the patient wasn't taking these at the time. Patient's allergies have been brought in, and we can mark whether the patient is independent and functional. And that's basically it. And then I can send this off by secure messaging, in this case to Sam Costello, using HealthLink, and that's it. And there's a record of the referral there. It's also, of course, in the referral section here, so it can be viewed later. The colonoscopy. All right, now here's a screen image of how it looks in Communicare, and you'll see it's very much the same, and it's the same thing in Genie, using their own fonts, of course. Now, once we've sent the referral, the colonoscopist can use that information to assess the patient's ability to undergo the colonoscopy, whether it's safe for them to have it, tell us if it might not be. And if the colonoscopist thinks it is a fair thing, then she or he will arrange that. To help GPs, there are some important, useful clinical practice guidelines on the Cancer Council's website for people with symptoms, and also for people under surveillance. In addition to this, the Commission has produced a very short video to give patients information, and this is probably useful for us to use to refer people to. We're going to play that now. It's less than 2 minutes.
A colonoscopy is an important test that examines your bowel to diagnose bowel disease and cancer, the second most common cancer in Australia. The Australian Commission on Safety and Quality in Healthcare has developed a clinical care standard for colonoscopy. Find out what you need to know when you've been referred for a colonoscopy. You need to know your rights, your choices, and your responsibilities. You have the right to have your bowel examined by a qualified and well-trained person at the right time and in the right way. Know why your doctor wants to examine your bowel. Receive your results with a clear written explanation so you and your GP can understand what happened in the examination, what was found, and what to do next and when. To be informed about all the things you can do to reduce your risk of future bowel disease. You have the choice to go ahead with a procedure now or later, or choose other options with your doctor. Discuss the medicine you can have to relax you. You have the responsibility to always tell your doctor about your health, your lifestyle, and any cancer in your family. Empty your bowel properly. It may not be very pleasant, but if you don't follow the diet guidelines and drink all of the sachets given to you, you may need to have another colonoscopy. Reduce your risk of bowel disease and cancer. Exercise, eat well, and do the poo test regularly.
right, now after the colonoscopy, of course, very importantly for GPs, we want to know the report of what was found. We do want to receive copies of the histology. And most important, we want recommendations about follow-up that we expect to be consistent with the national evidence-based guidelines. And in some cases, of course, when cancer is found, if it's advanced or other serious problems are found, the colonoscopist might have to get on and arrange some urgent care. To help the colonoscopist report to us, the Commission has developed a template that they can use for that. And also a template for the colonoscopy, it's a hard word to say, colonoscopist's letter back to us, just setting out some of those things again. All of these templates are available on the Commission's website. And in particular, if you wanted to download the referral template, it's there. And now we have some more polling questions. Now, it's probably nearly long enough, so I'd be interested to hear the answers.
I'll just give them a couple more minutes.
Yeah.
There's still some answers going on.
Okay.
Yeah, I think that's good. So the first question, how likely is it that you'll try using the referral template that we've shown in the webinar? 60% said they will definitely try using it. 32% said they'll probably try using it. So it's gone up to 31 now. So that's 93%. And just 8% won't try using it. So I think that's good.
All right. Yeah, so I think that's encouraging.
Yeah, and also good that 92% of respondents said they found the webinar useful. So that's really good.
Good, that's very nice to know. And now we're coming to the questions and answers.
Thank you. I'll just ask Siobhan and Anne Duggan to turn on their cameras because both will be helping with questions. Here they come. There's just one question. If other people have questions, please type them into the Q&A box. This one came quite early. Do the request indications match the Medicare rebatable criteria?
Yes, if I may answer that one, Oliver. The objective certainly has been for both the MBS review and for the colonoscopy clinical care standard to try and improve the appropriateness of referrals for colonoscopy. One of the things that you might know from when we looked at MBS colonoscopy across the country, according to where people live, there was, even if you standardise the data for age and gender, there was a 30-fold difference in the rates. And it wasn't that, the feeling was the rates in the highest areas were much higher than you expect given the epidemiology of disease. So there was a sense, and there was also, people had a view from their own experience that people were being referred for colonoscopy too frequently. That's not saying that that was the GPs doing it, because of course, once a patient's had a colonoscopy and has polyps, it's the proceduralist who then makes the decision as to when they should come back. So both the MBS item numbers and the colonoscopy clinical care standard, and I should not say both, but also the NHMRC guidelines are all designed to improve the appropriateness of care based on best evidence, and so that people are getting the colonoscopies when they need them, not getting too many, not getting exposed to risk without benefit.
That was a very good question.
Mm.
We have another question. Can this referral template be used for public hospitals as well as private specialists?
Yeah, and
absolutely. Yes. So what we did with all the templates, it was really designed to help the system. Many people already have templates, and I know that some of the jurisdictions have referral templates, and health pathways are quite common across the country. So it's not designed to replace what's out there. If out there is absolutely appropriate and built into your system, it's designed to help people not having to go and sit and develop their own referral template, because we recognise that there are many parts of the system that are really busy and just don't have time to be doing this sort of stuff. So the Commission's view has always been, do as much as we can to support the system and then give it away. So everything on our webpage is there for people to just take and use. And even if they want to modify it, that's great too.
There's an expression that's used by one of our prominent GP colleagues about he's heavily into quality improvement, and he says, steal shamelessly.
Yes, absolutely. And we'd also be interested in hearing from people if they think that there are other things that we could do to help improve the consistency and the standard of colonoscopy and the quality.
Mm-hmm.
What we've done so far is really targeted on what we thought were the big gaps in the system. And as Oliver showed right at the beginning, the clinical care standard has really 9 focus areas, because that was the areas where people were saying, look, there could be improvement here. And so the referral templates, certainly as a gastroenterologist, I feel that at times you get not enough information. So that was a sort of consistent measurement. We did that. But as a gastroenterologist also, bowel prep, I found, was a real issue. So it was really a wake-up call for us to spend more time talking to patients about prep, and then we did that video to make it easier for people, particularly with different health literacy levels, to understand the importance of bowel prep, so they didn't end up with a repeat colonoscopy or a suboptimal colonoscopy.
Being involved in the working group made me realise that I didn't know what colonoscopists needed to know about my patients. I mean, this is the thing. It's very good to have had that dialogue, because we can't always be aware of that. So that's where the referral template is very useful, I think.
Yes.
And
I think we failed in not also giving back to GPs consistently the information they need to continue to manage patients. So that's why that last quality statement has been so important and hopefully so useful. Sorry, I interrupted you, Siobhan.
No, I was just going to finish up and say that that was a common question that we were asked in the past, was our referral template compulsory? And the overall, it's not. But if you don't have anything that to refer patients, then this would be a worthwhile referral template to download. And like that, we did reach out to the PHNs about using the referral template, and the overwhelming response we got was they really liked the template, but they'd only use it if it was embedded in their software systems, which was why we engaged with the vendors and the 5 main software systems that have now implemented, as Oliver demonstrated during the presentation. So we have a few more questions now.
We do. So after the colonoscopy, if no cancer is found, do the colonoscopists inform the bowel screening program regarding this finding? Reason I'm asking is a patient may get the test kit every 2 years. I wonder if it will be withheld till the next repeat colonoscopy.
That's a great question. It's only been recently that the National Bowel Cancer Screening Program has connected up the colonoscopy with with subsequent FOBT tests. So if a patient has a FOBT as part of the National Bowel Cancer Screening Program and then it's positive and goes on to have a colonoscopy, then they won't get the kit 2 years later, they'll get it 4 years later. The problem comes when people have their FOBT that's not part of the National Bowel Cancer Screening Program, and that doesn't get picked up. So there's certainly been a lot of work done with the National Bowel Cancer Screening Program to improve those sorts of issues. But at the moment, there isn't any connection to other systems, so that the patient will get it 2 years later. And if it were positive 2 years later after a high quality colonoscopy, then it's very unlikely to be a true positive. And so you really don't want people to be having a FOBT test within 2 years of a high quality colonoscopy, because you just then create anxiety, create that sort of scenario where people feel, well, I've got to repeat this just in case, because I don't know why it's positive. But the guidelines would say repeated in 4 years, and many people would say, well, actually a good colonoscopy provides better cover than even 4 years. But at the moment, the consensus is 4 years is the earliest.
Hopefully now, and the National Cancer Screening Register will receive results from FOBTs done outside the national program, which will then feed back to the national program so it knows the patients had that FOBT. That's the theory anyway.
Yes, it's great to see the progress that's been done with the National Bowel Cancer Screening Program as well. And it's important to say that, in fact, the Commonwealth funded the Commission to do the colonoscopy clinical care standard. What it asked was for the Commission to look at a model of care for colonoscopy in Australia, because they knew that the National Bowel Cancer Screening Program was rolling out FOBT testing to everybody between the age of 50 and 74 by 2020. And so they were very concerned about people being exposed to colonoscopies and the risk of harm, and doing a whole lot of colonoscopies and the risk of not high quality. So it's great to see the very complex system coming together, I think.
Okay, the next question. How is the Commission ensuring prompt response to referral to public clinics and colonoscopy in the recommended time?
Well, there's a lot of work being done concurrently. So, and it's not really the Commission's mandate to do that, but we're certainly working and know what's going on across the system. So so the Commission happens to be based in New South Wales, but we've certainly been talking as well very closely to a few other states. But one of the things that actually has been a problem in the public sector is the whole issue for going from the patient being referred up, the referral quality, the patient not knowing why they're there, not wanting the procedure, the colonoscopy not being good enough, and then the patient taking up a space to have a second colonoscopy. So there's been a lot of work done. If I just take New South Wales, for example, and I myself come from Hunter New England Health, a few years ago, we started a direct access colonoscopy service where the referral letters came up to a trained endoscopy nurse who reviewed the letters, who checked the patient hadn't had a recent colonoscopy, who triaged out the people who were complex, so they went to clinic, and the people who were straightforward, she then rang, talked about them through a colonoscopy, talked them through the prep, and the patients came up to a booked list. And that was shown to have a huge impact on waiting lists. That's now rolled out across New South Wales. And just today, I've seen Victoria's triage category. One of the things I think that there's certainly been a huge problem in the public sector across the country, but one of the problems has been, how do you get good high quality triage, and how do you ensure you're not wasting triage spots? So there's a lot of work being done in a number of places. And I know, for example, that I just saw also today Queensland's approach. So if in fact services have a clear categorisation that goes out across the system, everyone knows it, everybody gets a high quality colonoscopy, so they're not repeating and wasting space, and everybody comes back at an appropriate time and not too early, then automatically you've created an inordinate amount of capacity in the system. So I think the colonoscopy is just one of many strategies to try and improve that. I think the other thing to do is we've got to understand the epidemiology of disease, and upper GI disease and upper GI cancers are far less common than bowel cancers. And I think we consume quite a substantial proportion of our endoscopy list in the public doing lower value gastroscopies than colonoscopies. Looking for a gastric cancer is in the average person is much less likely to be found. That patient is much less likely to be found, an eighth to a tenth less likely than a bowel cancer. So if you want to use the reward, if you want to get the access going, you've got to triage according to the epidemiology of disease. And that's why that referral letter of risk factors is useful. I hope that's answered that question. I think I've probably answered more than that question.
Great. Who is responsible in recalling patients for future colonoscopy, especially for patients with a positive finding, for example, polyps? Is it GPs, specialists, hospitals?
Oliver, do you want to take first bite?
Well, that is a very good question, and it's probably shared, because clearly if we are the patient's usual GP, and we know that there has been a need for some follow-up, I think we have to take that responsibility on. And I know that many of the colonoscopy services, of course, now run their own recall systems as well, which is probably a good thing. It's probably safer that there's more than one party involved. But yeah, Anne might like to comment from her point of view.
Yeah, I've always had the view that I am a consultant, and the GP has asked me to consult on this patient, but the GP is the doctor who coordinates and oversees patient's care and communicates with the patient best. So I certainly take the view that my responsibility is to inform the patient's GP and the patient of what I believe are the next best steps. But I try to actually make sure that there's good continuity of care between the GP and the patient. I think you play a pivotal role in holistic care, and I don't support the idea of eating into that.
Great. Now, this one is a bit long. I've got two parts to this question, or a bit of a question and then a comment. So, are there accepted standards for timing of colonoscopy for certain indications? In my public hospital, it can take 12 to 18 months for someone with iron deficiency anemia to have scopes. The person says, my experience is that people who are symptomatic or anemic and therefore more likely to have disease than a positive FOB wait longer to be seen in the public system.
Yeah, look, that's a very good point. And I do know that, and I spoke, one would think I spent all day on colonoscopy, but I did speak today to John Emery, who's working with a group in Victoria to develop a risk assessment tool, because I think the question of what is the pre-test probability of iron deficiency anemia versus abdominal pain for bowel cancer is an incredibly important one. It's very important for everybody to have that shared view based on evidence, because I do think that triage should be based on the likelihood. Now, if you take iron deficiency anemia, then I do know from the data that for an average person, average female under the age of 50, we do a lot of colonoscopies, many more than we do on under 50-year-old males. And if you think about it, it turns out they've got menorrhagia. We didn't know about it and didn't ask about it and didn't think about it. And I've seen that data from both colonoscopy data, gastroscopy data, and capsular endoscopy data. So risk stratification is based on a number of factors: symptoms, age, and all those cofactors that make up your risk. I think that the more we get the message out there, and the more that jurisdictions take on a clear, transparent, testable approach to how they triage, the better off we are. John, Oliver,
I was going to just comment from the GP point of view. I've seen some research recently, just to reinforce the point about menorrhagia, that it seems there are a lot of women out there who are having heavy periods, sometimes disabling them so they can't go to work and so on, and they haven't told their GPs, and the GPs have never asked. And it almost makes me think that if we're referring a woman under 50 with iron deficiency anemia, that should almost be a question in the template saying, have you checked on this?
Yes, I think that's a really important. The Commission did a clinical care standard on heavy menstrual bleeding because of the so many messages we're getting about people ending up seeing the wrong doctor, or ending up with a hysterectomy when there was, the all medication, IUD, endometrial ablation, all the options. So and it's quite clear, you're absolutely right, that I think lots of times we don't ask. And it certainly raised my awareness, and I'm much more alert to that and ask many more questions now, and do not infrequently find young women who've actually got menorrhagia, and off they go back to the GP for a discussion. I think we can do a lot. Just going back to that point about iron deficiency anemia and the waiting list in the public sector, I do believe there's a great opportunity to improve the waiting times, i.e. reduce the waiting times if we work harder at triaging as a system, not as individuals. I've always, as a hospital doctor, thought it was bizarre that if you came and saw me as opposed to Oliver, you get your procedure not based on your need, but based on my waiting list or Oliver's waiting list. It's just, it doesn't make sense for a public hospital. In that circumstance, Oliver, you were a colonoscopist for that example.
Another question, what is the advice re anticoagulants if polyps or biopsies might be taken?
Yes, so, aspirin's fine, but we really do want to balance the risks and benefits of being off your NOACs and your warfarin. In general, you try and defer somebody who's had a recent pulmonary embolus who can't afford to be off anticoagulation, but anyone else, then there's good guidelines, and I use the American guidelines of how long you should stop and then start. And we're doing it not infrequently now with all the NOACs around. Yeah, but it's very important to have that conversation with the patient because, as you know, the risk may be small to throwing off a clot pre-procedure, but it does exist. And occasionally I say to patients, well, if you don't want to stop, there is an option of doing the colonoscopy on the NOAC, but I won't be able to do anything. But if there's no polyps, you're fine. But if there are polyps, we'll have to do it again. And most patients don't, that's obviously a very heavily resource intensive way of doing it. But occasionally somebody will want to do that because they're fearful, absolutely fearful of stroking out.
That's all the questions we have at this point, unless there are any more forthcoming.
Shall we give people a little minute to type in something?
Why not?
Can you see when somebody's typing?
I can't see when somebody's typing.
Oh, I was going to say we'd
pop up at the end.
Then we'd know for how long to pause.
No, as soon as they finish their question, we'll know. It tells us.
Anyway, I think it's been very useful. Some really good questions that have come through. So that's been terrific.
Yeah, originally I did suggest, would we have a problem, a slide about the problem we're trying to solve? And my first point was going to be, apart from access, long waiting times in public or the private fees, and that's clearly a major issue. If we can reduce the number of inappropriate requests and colonoscopies being done inappropriately, that will go, I believe, a long way towards improving the waiting time for people who do need the colonoscopy. So GPs have a very important role.
Yes. And a number of years ago, one of the South Australian public hospitals demonstrated if they applied the guidelines to their patients waiting on their waiting list, the surveillance guidelines, they created an enormous amount of capacity. So it's an opportunity. It's hard work to do it. You've got to have the resources to do it, but it's clearly a very important issue now that more and more people are having participating in the National Bowel Cancer Screening Program. And I think your point that you made about not doing an upfront colonoscopy for the average person, I think is very important, because I think that's also blocking up the system with risk without necessarily great benefit.
Yeah, we know for GPs, we want to offer our patients the best care. It's tempting to say colonoscopies are much more definite and better test in quotation marks. Why don't we do that? And it's very important that we understand the reasons why that is not a good idea, and because of the exposure of the patient to risk and the costs involved and the anxiety it can cause, and then the whole thing being perpetuated.
Yeah, and that's why the alterations of the MBS item numbers is not an item number for just doing it because you want to do it. Yeah. Have we got any questions?
We have got a few more questions, so it's good. Has there been any feedback from colonoscopists whether they find the template useful or easy to triage patients?
I'm not aware of any feedback yet. I mean, we certainly had a lot of input into the template, enthusiasm for developing the template, but we actually haven't Siobhan, are you aware of any, or Oliver, aware of any feedback?
Well, that's what I was going to say. No, I mean, we haven't been provided with any feedback apart from these webinars where we did we had a colonoscopy, a colonoscopist webinar there recently, and the feedback was that they thought the templates were terrific and that they would use them, or would ask, ask that these be used. And again, when we put the templates together, it was with specialists from around the country that helped obviously put these together. So their input was, well, what is the information that we really need to know when we're getting a patient referred to us? But yeah, we haven't.
It is an excellent question, and it wouldn't be a bad idea for the Commission to survey even a small sample of 10 colonoscopists in 6 months and ask them, are they seeing the template being used coming through, and is it actually helping?
Yeah, terrific question. Thanks for that.
Yes, thank you very much. We will use that.
We've got some more. Is there any work being done on the post-polypectomy surveillance guidelines, since they were very complex, especially for GPs to follow?
That is a sadness in life for me. I did try very hard because ideally you want a one-pager, which, like the old surveillance guidelines, is a one-pager which I used to be able to take off my wall and say to the patient, here is what you had, this is you, this is what the guideline says we should do next, and then after this is what the options are. It's still being worked on, but I think it'll be very hard to create it because I think we've made the surveillance guidelines too complex. One has to have, you want something to be usable. It's even I have, well, not even I, but I think a lot of people have to keep looking at the guidelines to remember, even though we're using them frequently.
I mean, as a GP, I wouldn't personally try to look at those guidelines, I don't think, but I would be depending on the colonoscopist to tell me where they think the patient is and what needs to be done.
What has made the system easier is that the MBS item numbers for surveillance are based on evidence, based on European guidelines and American guidelines use high-level evidence, and they're simpler. The MBS the MBS item numbers are based on evidence, and they just make it very simple as to which group should have in 1 year, which group should have in 3 years, which group should have in 5 years, what are the other categories. So that's the other way of working out what's quite simply what should happen.
And I wonder whether in the report back to the GP, if that's the case, whether telling the GP what item number was used would be a way to communicate that as well.
I think that's a good idea because, I mean, at the end of the day, one of the things about the MBS item numbers for colonoscopy are that patients won't be eligible if they come up too soon. That was part of the system put in place intentionally to try and promote appropriate care. You've always got the item number 32222, which says you can do a colonoscopy if somebody's developed symptoms outside their, it's no longer surveillance, they've got a problem. But for surveillance, yes, it's not remunerated if they're coming back earlier than what the evidence would say they should. That's a good point, Oliver. We'll think about that.
We do have another question. Can you comment on advisability of low-dose aspirin for patients aged 50 to 70?
It's a really interesting question. There's emerging evidence that there is benefit. The studies would say after about 20 years. I should be able to tell you more, but I looked at it just recently and thought I must sit down and go back to the papers. So it is a thought. The question, the risk, of course, is what's the peptic ulcer rate? But I have somebody at the moment who's just 50 with a strong family history of bowel cancer. And I just did his colonoscopy and I said, no, we'll meet up next week. I think we should talk about aspirin. He said, yes, you mentioned that before. And it's something to be really considered. But it won't change the risk in 5 years. It'll be long duration.
That's a very interesting question. That's the 50 to 70-year-olds. And I don't know whether you have heard, but the GPs would know. We've recently had the ASPRE study, 19,000 people in the US and in Australia, healthy people over 70 taking 100 milligrams of aspirin or placebo, to establish whether they're more likely to stay alive and well doing that, and from all causes. And the conclusion was it does them more harm than good. It should not be given to people who are well at average risk. And so assuming all that, because that was one of the big questions, of course, over the years. But this is people over 70. That's different from the 50 to 70-year-olds.
And I think the other important point is that 50% of bowel cancer is related to lifestyle factors. So it makes no sense to talk to someone about aspirin, but not talk to them about being sedentary or having a poor diet or being overweight or smoking or drinking above the safe limit. And I think that's a real area where we just don't do enough. I think a lot of patients walk away from their colonoscopy not knowing that if they stop smoking now, the number of polyps they will develop in the future will be fewer compared to somebody who continues to smoke. Or if they lose weight now, not only will the cancer risk change, but their blood pressure will improve, the risk of diabetes and all those sorts of things. So I think it is important to be broad in the advice you give and comprehensive in the advice we give.
Yeah, diet is certainly a bit neglected. I was pleased to see it mentioned in the patient video from the Commission. I was enthusiastically telling one of my patients, a middle-aged man, about healthy eating and waxing lyrical about legumes and so on and the benefits. And eventually he looked baffled and he said to me, "What's a lentil?"
Yep. Dear.
Probably more of a comment than a question. The template seems to be a little clunky, having to tick many boxes that our standard specialist referral template populates automatically, so I'm not sure we'll use it.
I think I'll just speak quickly to that. Because, there are obviously, compared to maybe the referral template you're using, there are probably additional questions and tick boxes. The first section of it, though, all the demographic information, the past medical history, the medicines, all of that should come across automatically from your existing software system. And as we were preparing for this demonstration, we did come across some little quirky things going on with some of the vendor, different vendor systems that very kindly Dr. Oliver Frank is putting together some videos together that we can share with the different vendors to try and, iron out some of those clunky little issues. So you might find that, whoever's asked that question, you might find that, down the track, we might, these little issues might be ironed out slightly a bit better. But
yeah, I think it can be made much more efficient, and I've been asked to help with that, so it'll get better.
Yeah, somebody's saying the template perhaps should be editable in the software to make it more user-friendly.
Okay, good feedback.
Mm-hmm. Another one, IBD and cancer risks. So how often scope?
So there's no real, from the MBS point of view, there's no real real restrictions on timeline because patients with did you say IBS or IBD? Sorry.
IBD.
Yeah, good IBD, not because IBS is not associated with cancer. With IBD, they often have colonoscopies for assessment of disease activity, etc. In terms of risk, there's good evidence in terms of if you've had pancreatitis more than 8 years, you should have second yearly colonoscopy. There's good guidelines around that. I won't quote all the sorts of different scenarios of how extensive your disease is, but it's quite clear as to the need for surveillance, and the MBS support guidelines support that. We didn't actually go down to doing much at all in terms of IBD because the management of IBD and the need for colonoscopy in IBD is so driven by your response to treatment. It's not just looking for cancer, it's because it's your disease activity to some extent that drives your risk of cancer. So the most important thing is to be under a specialist who does IBD all the time and who will drive your frequency of colonoscopy based on getting you into optimal scenario, optimal care, and hopefully in remission. So I hope that answers that question.
Thank you. That's all the questions for the moment. But last time we said that, there were more.
guided by you, Mel. Do you think we're going to get some more, or shall we call it a night?
No, they've been a very good set of questions, I think, and all of practical importance for GPs.
Good.
That does seem to be all.
Right.
All right, we can finally come on to our last slide. Over to Anne.
Yes. So really on behalf of the Commission, I'd like to thank Oliver very much for all the work he's put into this presentation. It's been a fantastic presentation. I've certainly learned more about GP referral templates and systems than I've ever learned. But I think it's been great to see this presentation occur, and it's been great to have the participants online, because it's fantastic to get questions and to get an opportunity to convey to people what can be, I think, an improved way we do business in regard to our patients who need colonoscopy. So most grateful for you to taking the time out of your busy diaries. Most happy to receive feedback about what we could do better. And most happy if you want to talk to your colleagues about the colonoscopy clinical care standard. So on that note, I'd like to thank Mel for being a fantastic coordinator, and I can't remember what, not compere, I can't remember what the word is, facilitator, and for Sharon and Anne for thanking, but for you, the audience, for coming, and Oliver for presenting. Thank you.
Thank you, Anne, and good night to everybody.
Good night,
Somebody
everyone.
has just asked, will the slides and the video be available post-webinar? And I'm going to answer that one and say, yes, they definitely will on the Commission website.
Yep, definitely, and the other presentations. And
That's
with-
We'll get them up on the website in the next few days. Yeah.
Absolutely.
Thank you, everyone.